I found that the $20,000 piece could fall flat, you know? So I joined the people who wrote the piece initially. And I said, have you thought about lifetime pay? Because I have kids and was thinking about, okay, generational wealth. Like, what am I passing on to my children? Like, why do we all work so hard? And so we then looked at the lifetime pay gap, and it's $2 million. Okay, that's big. And when that came out, it's funny because the New York Times did a piece on it again with just more of a regular piece on the $2 million pay gap, and a lot of people on social media were like, "Not another pay gap study," because they thought it was $20,000, and then I had written like, "Oh, in full disclosure, like we know this is a pay gap, but we wanted to quantify it this way so people would see that $2 million matters. It's more than just $20,000. This is real generational wealth and impact." Later that week, one of my friends, who's a hospitalist, texted me to be like, "Turn on SNL."
Welcome to How I Doctor, where we're bringing joy back to medicine. Today, I'm joined by Dr. Vineet Arora, the Dean for Medical Education at the University of Chicago's Pritzker School of Medicine. My own med school dean of med ed was extremely important to me in my own medical training, so I am so excited to have her on the program today. If you've read about duty hour reform, women's physicians' pay gaps, or how burnout impacts the medical workforce, you have probably come across Dr. Arora's research. She's been at the forefront of making these invisible challenges visible and pushing for solutions that actually work. In this episode, we'll talk about why pay and promotion gaps still exist in medicine despite decades of progress, what women physicians can do earlier in their careers to avoid getting left behind, and how male colleagues can step up as allies. I am so excited to have this conversation with Dr. Arora today because I think her work doesn't just diagnose the problems, she actually points to treatments, to action solutions that every physician can take today. Dr. Vineet Arora, welcome to How I Doctor. Thanks for being here. Before we jump into the episode, I want to thank our sponsor, Evidently. Evidently is the clinical data intelligence platform built to help physicians harness the ocean of patient data they're drowning in every day. From chart summarization to AI-assisted note drafting and denial appeal support, Evidently makes sure the right data shows up at the right time. Physicians using Evidently report spending less time hunting through charts and more time focusing on patient care. That's why they've become a trusted partner to health systems looking to improve documentation, quality, and revenue sustainability. The company is led by providers and AI researchers that are dedicated to reducing documentation burden and helping clinicians practice at the top of their license. If you want to see what Evidently can do for your hospital or your practice, reach out today at www.evidently.com. Now, let's get into today's episode. Before we jump into today's episode, I want to give a huge shout out to our first ever How I Doctor podcast sponsor, Abridge. Abridge is the leading AI platform that drafts structured, clinically useful notes at the point of conversation. Clinicians remain in full control because they review and finalize every note. With Abridge, many clinicians report reclaiming time and reducing their documentation burden, myself included. I've been using Abridge in my role as a practicing emergency physician in San Francisco, and clinicians who use it report up to an 86% reduction in effort writing notes, a 78% reduction in cognitive load, and 70% decrease in after-hours documentation. The company was also founded by a physician and is completely dedicated to empowering clinicians, which is what makes them the perfect first sponsor for How I Doctor. If you aren't yet using Abridge, inquire with your IT department today or reach out at abridge.com/contact. Thank you, and now let's get to today's episode.
Thank you so much for having me, Graham. And, please call me Vinny. It's so great to be here with you.
Oh, it's amazing. Thanks for joining us today. Let's just kick it off talking about gender inequality. You've published widely on gender inequity in medicine. What made you first get interested in this area of research?
I'll take you back many years. I actually was doing a lot more work and research in quality and safety and shorter work hours for residents and handoffs. And I was reviewing a paper in JAMA Internal Medicine that a female editor in chief, a prominent female editor in chief, had asked me to review, and it was on the gender pay gap. And it was a wonderful paper. It was a paper that controlled for all the variables you wanted to control, and they found that they found a $20,000 pay gap after controlling for all of those things, which was not surprising because other researchers had consistently found this $20,000 pay gap. And actually, paper was well done. No issues. As the reviewer, though, when I got to the discussion, they basically said women need to negotiate more. That was the crux
That
of
was
the
the takeaway. Yeah.
yeah, and I realized reading this paper that I was suffering from a pay gap, and it was like when you read a paper, sometimes you get personally fired up, and so I was personally fired up, and I wrote that the paper was well done methodologically, but it required some thought on the discussion, and I wrote what I would write in the discussion, which is things like system solutions and pay transparency and other systematic things to think about, and of course, women need to negotiate more, but other things that what can men do, what can others do. So I was invited to write the accompanying editorial for this
Oh, yeah.
and so, okay, that was exciting. And I got to write the editorial and it came out. When it came out, I was called by the New York Times, by Catherine St. Louis, who is a writer at the New York Times. And she said, your piece resonated with me. Because I actually am in a dual career marriage, and I had written about it's not credible for me to get a counter offer. That's how people's salary goes up. We need to fix the system. And she said she actually had the same problem because it wasn't credible for her to go be Wall Street Asia bureau chief with two kids married to somebody also in media that everybody knew. So I realized there was some commonality there. And so, she quoted me in the article. Her piece ended up being on the front page of the New York Times online edition. And she asked that my picture go with it, which was odd because I was like, well, what about the authors? And she said the authors are all male. We wanted to put the voice of a woman physician on the front page. So of everything I've ever done, and a lot of the work I had done, had influenced policy, had done a lot of great stuff. This got a lot of traction at that
Yeah.
in my life because it's like it entered the mainstream consciousness and people all the way in India, my relatives in India, the headline said, "Doctor paid less" with my picture. And so, my WhatsApp was burning up. And so people still remember that moment. So that's kind of what happened to me and how I ended up in this space.
I'm curious, how did your local colleagues at University of Chicago respond? Was there public support? Were people quietly whispering, "Hey, I agree with you," or what was the response?
There was a lot of public support. And I should say that my institution has done amazing work. And I work with another physician, Dr. Julie Euler, who chairs our women's committee and has been doing it for years now, does it at the institutional level. And I've authored with her about our institutional journey. And so it's been very important for me to basically align with the work that is going on with our institution. Now, one thing that I will go back and say with the paper that we had read is that the pay gap is not universal. I looked at all these specialties, and one specialty had no pay gap at that time, which was radiology in those 18 public med schools. And then there were three or four institutions where women made more than men after they controlled for. So I think the other thing to keep in mind is that it's really easy to talk about discovering any type of difference, disparity, whatever you want to call it. That's sort of the easy part. How to understand it, is it a problem, solve for it? That's the
Yep.
hard part. And so I was reading the paper that how do we take the positive practices that are going on in these fields and then move the field forward and show that there are places where things are equal.
We did an analysis that doesn't sound nearly as comprehensive as the paper, but we looked specifically at emergency medicine,
Yeah.
my specialty, and really one of the reasons was I think ER doctors intentionally, one of the things we're proud of is we kind of think of ourselves as interchangeable. Like I can email my group and anybody can pick up my shift. That, we can trade because we're all interchangeable parts. We're all the same, right, in some way. And we like that equality and we like that. But then when you look at it, we found I think a on average, $20,000 difference in emergency medicine as well.
Saw that, yeah. That's a common number that's found, yeah.
Yeah, and so it is interesting that even in a field where I think my group is at least maybe even more than half female,
Yeah,
um, in even in areas that seem like we are just interchangeable parts, we're a warm body in a seat, we are shift workers, we're all equal. That may not be true, and then to your other point, it gets even more complicated when you start to break it down by, well, are you a salaried?
yeah.
Are you RVU based? Are you hourly? Um, so it is interesting that you can see those differences. And then we know this being evaluators of data as physicians, like as you start to cut the data and look into, subgroup analysis, it gets even more complicated and complex too.
Yeah, no, absolutely. And you mentioned a lot of interesting things like the intersection with our physician payment system, which can be very obtuse. But certainly in primary care, there's other literature that shows that data shows the practice style of women physicians on average. I want to say on average always because it's not fair to generalize
Yeah, of
across
course.
everybody. But on average, women physicians tend to, take longer time with patients. They're rated better. Satisfaction is high, but there that might lead to lower patients seen, and so that would be lower RVUs. Um, a lot of the $20,000 studies control for those, and so
Yeah, totally.
they try to control for that. But you can imagine, okay, well, perhaps that's something to think about, and then the answer there would be, is there a reason why that work is not valued, right? And so that's something to keep in mind, right? The second piece that you raise around emergency medicine is fascinating to me because I've had an opportunity to study emergency medicine trainees. So what happened to me is after being a medical education researcher and a medical educator, I started to ask these questions after I reviewed the paper thinking, well, if this is happening for faculty, what's happening at the training level? Because at the end of the day, most of the way in which salary is advanced, is through initial offer, maybe a retention offer, but there's also a lot of merit pay, right? I started thinking a lot about merit because merit is based on evaluations. And that is actually the currency of how we advance trainees is their evaluations. So emergency medicine was fascinating because we had access to this database of real-time evaluations in emergency medicine for multiple sites. And that was important too to kind of make sure that we weren't just calling one place out, but if it's a systematic issue, it should be everywhere. So we had 33,000 evaluations of real time that were milestone based evaluations, sort of looking at how people advance. And we saw that at the beginning of residency, in a field where it's like pretty even, there was no difference between how female residents and male residents were being evaluated. But by the end of residency, there was a 3-month what we call promotion gap, where the women were lagging behind 3 months and sort of meeting their milestones. 3 months, that's like a quarter of a year, right? That is significant. And so it was like hard to explain why is this across so much data occurring,
Yeah.
it's a pretty big finding. We published that and then we went one step further to look at the narrative.
I was just going to ask. Yeah.
And so what was the story? Well, it turned out that when you look at the narratives, because people give their circle their
One through five, and then they'll write a couple lines about, yeah.
these seasoned sociologists at U Chicago who looked at all the narratives and kind of impartially like put it all together. And it turned out that when a male physician was struggling, he would get coaching level feedback, that would provide the opportunity to improve, and you would see the improvement occur.
Yeah.
But a female resident struggled, particularly with leadership tasks, not in the first year, because the first year you're kind of following orders, as you
Yep.
know, Graham. But in the second year of residency, when you're kind of team leader, code
Yep.
leader, running a trauma, the female residents would often get discordant feedback and they would be told either they need to be more confident. So Emma needs to be more confident in her resuscitations. The next month, Emma fictitiously is being evaluated by somebody else. Doesn't matter if it's male or female. Same discordant
I
feedback.
was just going to ask. Yeah.
That,
Yeah.
then Emma is told that she's argumentative. She argues too much with the attending and needs to be more passive.
Agreeable. Yeah, more yeah.
Yeah, more of a team player, okay?
Oh, yeah,
And then
yeah.
then the next month, right, then Emma is now getting punished again because she's, like, tried to, you know,
Recalibrate a third time.
not gotten
Yeah,
it yet. And so this was very interesting to our sociologists because this is also very common in many other industries where, women are having to take roles that are primarily when you ask the public that is mostly thought of as male dominated, then women are often punished for stepping into those roles because they are going against the gender norm. And
sure.
so that was very fascinating to us to see that qualitative story play out as to why this was happening not in the beginning of residency but in the end of residency when you're really needed to be a leader.
Hey, today's episode is brought to you by Abridge. We all feel the weight of clinical documentation that follows us home and chips away at our personal time. With Abridge, clinicians can change that. Abridge drafts a structured, clinically useful note at the point of conversation, all seamlessly integrated into Epic and customizable to your specialty while you review and finalize every word. Clinicians have reported significantly less after hours charting, improved satisfaction, and dramatically lower burnout. Let technology support your day instead of interrupting it. Visit abridge.com to learn how you can focus more on patient care and less on paperwork. Let's put the care back in clinical care. A quick word about today's sponsor, Evidently. Their platform turns an ocean of fragmented clinical data into concise, actionable insights. Chart summaries, note drafting, denial appeal support, HCC capture, so you spend time caring, not chasing. A transplant surgeon at a large academic medical center recently took transplant referral review from 2 hours to 20 minutes with AI-assisted chart review from Evidently. Physicians deserve workflows that improve accuracy, reduce exhausting chart biopsy, and help us practice at the top of our license. If you want to see how this might work in your hospital or your department, go to evidently.com. That's evidently.com to get started today. Vineet, when you're speaking directly with women physicians earlier in their career, do you have recommendations of the first 2 to 3 moves they can make to protect that earning potential and make that $20,000 gap disappear? Or
I think that a lot of institutions are moving towards standard pay scales for entry level. That look for that. That helps you, right?
sure,
And then ask about it. Like ask about what is being done in the organization to look at gender pay disparities. And if they don't have an answer, that could be concerning. And the third is look around. I think that a lot of times women may be, for a variety of reasons, being head of household, family, kids, etc., be more reluctant to take a look at an offer that might be a little bit outside of their mainstream. And I think that helps know your value, right? If you look at, and it also helps you ask questions, right? So it doesn't mean that you're falling in love and you're entering into a contract right away, but by looking a few more places, it actually allows you to understand contract negotiation as well. The one thing I will say is that a lot of times it's not the first job that's really the result of that creates the pay gap, because a lot of times there is entry level, like here's the standard. Do ask. You should definitely ask and put out what you want to ask about. So there is a lot of pearls around negotiation where what is your best alternative to a negotiated agreement? What's your zone of possible acceptance? There's a whole literature
yes,
behind negotiation. And so I encourage everyone to, get a book, read about it. I will say sometimes pay is less important than other factors. Or
absolutely.
you need to be very explicit about what it is that you're looking for and what you value. And then you'll have that fulfillment that you negotiated well for yourself because of what you value. So, for example, when I was a researcher, I negotiated for protected time to do my research. That was what I cared most about because I needed to get a grant. And that would be very different than negotiating your first clinical job. The key, though, is that's just your pay gap at the beginning, right? You have to continually re-look and understand your market to basically not fall behind over years. Does that make sense? And so I knew that I had negotiated well up front, but I, at the time I was reading the article, knew that I fell behind because I hadn't looked around. I hadn't really, it's like anything in your life. If you don't pay attention to it, you kind of fall behind, you know?
Yeah. Yeah, no one's gonna be looking out for, you to make sure that you're getting the raise that you deserve, or honestly, even just take the vacation time that you're supposed to be
Yeah.
getting. I mean,
Yeah.
if you don't advocate for yourself, no one else in the health system will do it. Everyone will happily just have you work every single day.
Absolutely.
I completely agree with you that it is not all about pay. When I created Off Call, I tried to say like pay is important, but it is one of many things that's important. I think one of the things to your point that is important is what are the other things that make this job good or bad? Do I feel supported at work? Do I have a good relationship with administration? How many patients am I seeing per hour? If I'm a cardiologist, how many echoes do I read per day? All of these things impact whether you feel like you are, I think control, autonomy is a huge one for physicians, and that you feel like you are empowered and like self actualized, that you're actually able to like make an impact and help the patients that you're seeing every day.
Absolutely, absolutely. I totally agree with that, and I certainly think, given the epidemic of burnout that we're seeing among physicians, you do need to factor in your work hours, your what is the landscape of your administrative work looking like? What's your administrative support? What's your nursing support? These are all very, very important factors. And we have a wonderful chief wellness officer here, Bree Andrews, who's spoken with me many times, and also, you know, uh, an expert in her own right. And she talks a lot about, a lot of people talk about joy in work. And then, there's this whole like yoga kind of, anathema out there as which is like, of course, it's not pizza or yoga. But she really,
It's not. You heard it here first, folks,
yeah,
on the podcast. It is
yeah.
not yoga. It is not pizza that
But
fixes
she
burnout.
talks about professional fulfillment, you know?
Yes.
So it's really like why did we like, I read a lot of personal statements, right? Nobody talks about pizza or yoga. They talk about wanting to make patients better, wanting to feel like they're connecting with patients. And I think that's really the challenge, is that the work has to be meaningful. We've all done hard things. We've all graduated from medical school. We've all done very hard things, but the more meaningful the work is, and the more you know you're making a difference in your patients' lives and that you're being empowered to do so, the more fulfilled you're going to be. And of course, work hours and time for family, all of that is part of it, right? But I would say I am constantly amazed by the number of people who do mission driven work as doctors, like on the side, it's
Yes.
meaningful, right? And, but they can't even think about like spending one more moment on a prior auth, So because that's not meaningful, right? Because they're like, it's an obstacle. So I think this is like, we've got to figure out how to restore professional fulfillment, for everybody, not just for women.
I love that. I love the meaning and the fulfillment. It just makes me feel like medical training, even pre med, there is sacrifice there. We have all agreed that there's some things we're not going to get to do in our 20s,
Yeah,
or
yeah,
there's some things that we're going to be giving up in our lives
yeah.
because we've said, yeah, we want to do this other thing that requires true sacrifice. It requires, we all probably are going to die younger because we did a bunch of night shifts, and like there's a lot of things that come
That could
with
be a whole
that.
other podcast, Graham, about sleep
Totally.
and mortality. Yeah,
Totally. But we miss out on holidays and birthdays and all these things because we were dedicated to what some people would call a calling. But I think we want that sacrifice to matter, that the sacrifice was worth it.
yeah.
And so that's, I think, where that professional fulfillment really comes in.
Well, and also I think that's where pay comes in too, right? Because
Yeah,
I know that, obviously, it is tricky because, people doctors are top earners, right?
totally.
But
Yeah.
they
Yeah.
worked really hard, and there is a value to being a doctor. And I've found that, the $20,000 piece is could fall flat, and so one thing that we did was, if you can't beat them, join them. So I joined the people who wrote the, the piece initially, and I said, "Have you thought about lifetime pay?" because I have kids and was thinking about, okay, generational wealth. Like, what am I passing on to my children? Like, why do we all work so hard? And and so we then looked at lifetime gap, the lifetime pay gap, and it's $2 million. Okay,
Yeah. I
that's,
totally believe that. Absolutely.
that's big. That's big. And when that came out, it's funny because the New York Times did a piece on it again, with just more of a regular piece on the $2 million pay gap, and a lot of people on social media were like, "Not another pay gap study," because they thought it was $20,000, and then I had written like, "Oh, in full disclosure, like, we know this is a pay gap, but we wanted to quantify it this way so people would see that $2 million matters. It's more than just $20,000. This is real generational wealth and impact." And so sometimes you do break through the public consciousness. So that was a moment where, later that week, one of my friends who's a hospitalist who has followed the work and interested, texted me to be like, turn on SNL. So I was like, okay, that's not usually what I was expecting to hear from her. So I missed it, but I turned on SNL like on the computer, Weekend Update,
Yeah.
Colin Yost, Michael Che. Michael Che looks at the camera and he says, a new study shows that female doctors make $2 million less than their male counterparts. And then he looks straight at the camera and he says, female doctors? And my husband and I were watching
That's a good Michael Che impression, actually.
learned. I've watched it so many times. Like, I was definitely like, had that like bittersweet taste in
Yeah.
my
Yeah.
mouth where, because people are like, "Oh my God, you're just on SNL." It As a result of that, a lot of people then called and emailed again to be like, "What can we do about it?" Right? And people started asking questions about it, and not just about the $2 million pay gap, but it was really about, well, why is this a funny joke? You know what I mean?
Yeah.
'Cause
Yeah.
we've had 50% women entering medical school since I was a med student.
Yeah. For decades. Yeah, for sure.
It was an interesting dialogue because remember that women are working against that stereotype, like, right? Of that gendered role to be a doctor. And so then you're being penalized for it. So that gets at the root cause. And so I've learned to highlight that it's okay that it broke through the public consciousness that way because it was still important.
Totally. When your raises are also percentage based, that's also where that $2 million comes from. So if I'm making 400 and you're making 380, but we both get a 5% raise,
Yeah. Yeah.
that spreads out the gap even further.
Yeah, people don't realize those early, you have a small gap initially, but the compounding year over year really does make a big difference.
And probably getting rid of your student loan debt. To your point earlier, $20,000 more, especially earlier in your career as you're trying to pay down your loans,
Yeah.
now means that you pay down your loans faster, which then means you have more expendable income for the future as well.
Actually, there's a stunning article that was published in The Atlantic. The article basically looked at earnings potentials of a primary care physician versus, and for the sake of the article, it was like a primary care physician who's a woman who might want to work part time versus going to be a nurse practitioner or or a PA, right? Because you account for student loans, right? And the time in residency, it made more financial sense to not become the primary care physician. And so I mentioned that because even though we're not here talking about primary care, and fields like pediatrics, which have high numbers of women
Oh,
in them,
absolutely.
um,
Yeah.
one really interesting, important note for physician pay is the specialty differences, and it is not random that a lot of women tend to go into fields that are more have lower pay. And why is that? Well, and it's even interesting, like, it's called pink collar work. We all are familiar with blue collar work and white collar. Pink collar work is professions that sort of value those, more feminine traits, talking, care. I mean, nurses, a great example, teachers, right? Fields that have suffered from low pay. And the literature actually shows that the more that women enter a field, the salaries fall, and
Wow.
so, and then when a male enters a female dominated field, the gender gap still exists, right?
Yeah. Wow.
So OB is an interesting example, so men are still more represented in leadership and also there's a pay gap, right? So just highlighting that there is something about this isn't like a one-off. You can't just fix it for one person or one institution. It's really a more pervasive phenomenon that's societally driven, you know?
And it's interesting. I'm just reflecting some of those, whatever we call them, traditionally more feminine skills or soft skills, I've heard as well. Often that is the art of medicine. I mean, it is those communication skills that makes the good doctor, separates them from the great doctor. It's that ability to convince the patient
Yeah.
or to speak to the family member, or those things are, we highly value in medicine as like this secret sauce that really is the expert clinician. But if you look at those, they may not be valued in the same way.
Well, we value it, in medical training. We don't pay for
Yes.
it on the
Yeah.
US healthcare dollar system, and so that's the challenge because we prioritize volume over, quality value these discussions. But I think this will resonate where I've definitely seen early women physicians, especially in primary care pediatrics, who spend a lot of time with their patients. Their patients adore them. They're doing they that's what they want to do. That's what they believe is high quality care, but they're being told that they need to go faster, see the next patient quicker, and sort of mold their practice style into, obviously more of an RVU generation mode, which makes good financial sense. I mean, that's sort of the unfortunate reality of the system, right? Which is that the system is built this way. But that disconnect leads to a lot of burnout. And I've seen women physicians leave early because they can't reconcile, like, not providing the high quality care they want to in the practice style they want to. Now, again, these are more anecdotes, but I do think that will resonate with some,
I think that was even a plot line on the Pit. Like, Dr. Robbie was upset that the young, I think Indian, I think she's maybe like an intern. She's playing
Yeah,
maybe the intern or like an R2 or something like that. And he's like, "You are too slow. You don't move the meat fast enough," is the ER version of that.
yeah,
And
yeah.
you want to do these crazy workups for whatever lead poisoning or toxic heavy metal, and then she ends up being right. She cares too much. She's too slow.
You know what? Actually, yeah, that is actually a great example. She cares too much, right? But the system doesn't allow for that. So, which I think that we need to ask. We know that patients value. I mean, just stepping back, we know that patients value those conversations and that quality. So we've got to think of a better way.
I know. Vinny, what role do you see organizations like the AMA, the AMC, specialty organizations, what role should they be playing in closing this gap? Do you feel like they're doing enough?
So I really credit the AAMC with at least for medical schools for the academic pathways where we do have more data. There's so kudos to you because it is hard to get the data on more the general practice. I do credit AAMC with very rigorous data that they make available around benchmarking salaries for all sorts of things like you have leadership role. Here's what the benchmark is. Here's what Midwest is versus West Coast. Because this knowledge is power and it allows you to negotiate effectively. And it allows the organization also to be like, where should I put the offer? So it provides a little bit of a framing as opposed to coming in from nowhere. And even though you want to aim high, you don't want to also sound like you're unrealistic.
Yeah, yeah.
Because that's also doesn't bode well for you either. So if you happen to have questions, many deans of faculty affairs, or if you're at an organization that has a women's, committee or some type of a role like that, those folks have access to this compendium often that they make available that allows you to look at where you are and where everyone is by percentile, 25th, 50th, 75th. And many organizations actually will say, for example, we offer the 50th where there's no wiggle room on the first negotiation. They'll just say, here we are, we offer the 50th, So some places have done that. Others have used that to say, okay, we're going to do equity. We're going to do equity corrections, and we're going to make sure that everybody is at this level. Do you see what I'm saying? So that data has very, very helpful, and I credit the WMC with that. And then in terms of other organizations, I do think having convening and having the conversation, because a lot of times what you need to do is break through to the C-suite and the dean's office to say this is an issue, right? Well, then it's like, well, who's going to break through, right? I do think that that is where those bigger organizations have a role in sort of getting that into the leadership consciousness, which they do.
I've always thought that the lack of transparency always, benefits the employer. It's the power dynamic there. But it was interesting. I was talking with the chief people officer of a healthcare company, and she even told me that she would love to have more transparency so that she can write better offer letters. The whether it's younger millennial physicians having different values and interests, and maybe they want more vacation time up front, or they want more help with their student loans, but like, she wants more transparency so that she can make a competitive offer that's as good as the one down the street, because she doesn't really know. And because the negotiation is so rigid, and both parties don't want to speak out of turn in some way, she actually is like, I would love to give someone something that they want more than something else. I just don't know what they want.
Yeah, I mean, that's why it goes both ways. It's definitely something where creating that transparency does help. It's not enough, though. I do want to say transparency alone is not enough. Some of the things we've done here at University of Chicago that some of my colleagues have written about are really thinking about recognition, because so much of that merit piece is sort of, did you win an award, right? But then you look at awards. Dr. Julie Silver shows that even though in some fields like dermatology, 50% women, like 0% had won the Arnold P. Gold Humanism and Medicine Award. Which,
Wow. Wow.
I use that as an
Yeah.
example. It's not
Sure.
neurosurgery to be like, humanism in medicine, that's it's not, it seems unlikely, after 10 years that there would be only men. And so it's sort of statistical, right? You need to look at that. And so at least some of the stuff that our group has done is looked at, how do you form committees to sort of think about nominating women into roles? How do you create workshops to teach women and others who want to come about negotiation skills? And so the awards work has been really interesting, because the group was able to show that they, through concerted effort, and I was actually the recipient of one of these awards where, I wouldn't have put myself up for the award. They were like, can you give us your CV? And why wouldn't I put myself up for the award? Well, bizarrely, there's a lot of literature that highlights that women are not forthright about their accomplishments. And so, Castle Connolly's, best surgeon,
Top. Yeah. Yeah.
back in the New York Times, 16 faces, all men. Okay.
Wow.
For best surgeons. And we
Yeah.
know there's women surgeons, right?
Sure.
And statistically, this look very unusual. So I asked the question to be like, anyone know why this is? And somebody's like, oh, women are chosen, but in order to be on the back of the New York Times, you have to pay to
Yeah.
have.
It's a pay for play thing.
Yeah,
Yeah.
and
Yeah.
so then I'm like, I see. So there's something statistically different about women who are not, because they don't pay. Another best practice, this is where organizations can help spread best practices, is a group of women can come together, or and with men, is a great thing for male allies to participate in, or others, is to say, because I've run into men who also are like, this is weird. Why
This
would
is
I tell?
crazy. Yeah. Yeah.
And so, and we always have the quiet, there's always, so you can lump this in with people who feel uncomfortable with promoting themselves. And you can come in as a group and you can share with your little group of four, oh, I got a new paper. And then somebody else, it's so easy to advertise somebody else's success.
Yeah.
They can tell your chair or your chief or your medical director to be like, look.
Oh, that's a great idea.
And so then it's sort of self-fulfilling, because everyone does it for each other and people feel good. The group feels better. It's like a shout out. So I think this is where I think there are a lot of groups like Women in Medicine Summit that I'm a part of. I'm an advisor for, where the group is convening conferences to spread best practices to anybody around how to do this well in your organization.
That's great. Vineet, in our last 10 minutes, I've got just some kind of quick hits for you. What do you think the biggest myth is about gender equality in medicine?
Probably biggest myth is that it is easily solved for with pay transparency,
Oh, I love that.
you
Yeah.
know?
Yeah. What advice would you give your younger self as a woman leader entering medicine?
Don't be afraid to ask for what you need.
I love it. What gives you hope that the next generation of women doctors will face a better landscape than today?
I see a lot of these younger ones on TikTok sharing
Yes.
the pain, of balancing life as a woman physician, and I kind of grew up as a Gen Xer, and I really am in awe of the younger generation's ability to share everything from their mental health concern to I'm trying to deal with my kids and do this, and by making it real and authentic, I think it really moves the emotional consciousness of the public.
I'm just realizing I've never really thought of this, but yeah, of the physicians that I follow, like on TikTok, I think probably 80 or maybe even 90% of them are female. What's one negotiation tactic every physician should know?
Know what you're willing to walk away for.
Oh, great one. And finally, fill in the blank. The most undervalued skill in medicine today is
Listening.
yes, I couldn't agree more. Dr. Vineet Arora, thank you so much for being here. It's been an absolute pleasure to get to talk to you and get to know you.
Yeah, it's been wonderful to get to know you as well, Graham. Thanks for having me.
Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.